Now let's turn to a discussion of the protein metabolism pathways from the perspective of various high-yield disorders that can arise with aberrations of amino acid metabolism. The image on the slide illustrates a number of pathways in which selected amino acids are converted to citric acid cycle intermediates or acetyl-CoA. Let's zoom in on some of these pathways and their related disorders. The first disease to be discussed is phenylalanine hydroxylase deficiency, also known as phenylketonuria. The clinical manifestations of this disease are due to the toxic accumulation of phenylalanine and its deaminated product phenylketone, for which the disease is named. Affected infants are normal at birth, but if untreated, show slow development, severe mental retardation, autistic symptoms, and loss of motor control. Affected children may also have pale skin and white blonde hair. The disease can also be caused by a deficiency of the tetrahydrobiopterin cofactor. Due to the profound clinical consequences of this disease, all infants are routinely screened a few days after birth for blood phenylalanine levels. If found to be affected, these infants are treated with a lifelong semi-synthetic diet markedly restricted in phenylalanine, with small quantities being necessary since it is an essential amino acid, as well as increased tyrosine in the diet, as tyrosine will become an essential amino acid. Aspartame, which is an N-aspartyl phenylalanine methyl ester, widely used as an artificial sweetener, must be strictly avoided. Further, women with PKU who become pregnant must be particularly careful about their blood phenylalanine levels so as not to adversely affect the neurological development of the fetus, as inadequately controlled serum levels may lead to mental retardation, microcephaly, low birth weight, and congenital heart defects. The next disease is homogentisate oxidase deficiency, also known as alkaptonuria. The accumulation of homogentisic acid in the blood leads to a number of clinical manifestations. Its excretion in the urine causes the urine to darken upon exposure to air, a sign that is not present in all affected individuals. They may also have an accumulation of dark pigment within the cartilage, called ochronosis, which can be noted in the sclera of the eye and in the ear cartilage. Patients often develop arthritis in adulthood, beginning typically during the third decade. Arthritis is due to homogentisic acid being toxic to cartilage, inducing inflammation. This overall is a benign disease and treated by symptom management. Not shown on this slide, it is important to note that tyrosine is used to make melanin using the enzyme tyrosinase. A defect in this enzyme results in albinism. The next disease to be mindful of is branched-chain ketoacid dehydrogenase deficiency, also called maple syrup urine disease. This enzyme is similar to alpha-ketoglutarate dehydrogenase, and it catalyzes the metabolism of branched-chain keto acids produced from their cognate amino acids, valine, leucine, and isoleucine. In the classic form of the disease, infants are normal for the first few days of life, after which they become progressively lethargic, lose weight, and have alternating episodes of hypertonia and hypotonia. Also, the urine develops a characteristic odor of maple syrup. If not treated, these individuals develop ketosis, coma, and death. The treatment largely involves the restriction of dietary valine, leucine, and isoleucine. Also note that the urine of these patients can have a caramel color. Going further, let's discuss propionyl-CoA carboxylase and methylmalonyl-CoA mutase deficiencies. Valine, methionine, isoleucine, and threonine are all metabolized through the propionic acid pathway, which is also used for odd carbon fatty acids. A deficiency of either enzyme results in neonatal ketoacidosis from failure to metabolize keto acids produced from these four amino acids. The deficiencies may be distinguished based on whether methylmalonic aciduria is present, indicative of a methylmalonyl-CoA mutase deficiency, or by the presence of methyl citrate and hydroxypropionate, indicative of a propionyl-CoA carboxylase deficiency. A diet low in protein, or a semi-synthetic diet with low amounts of valine, methionine, isoleucine, and threonine, is used to treat both deficiencies. The next disease is homocystinemia or homocystinuria. The genetic causes of this disease are rare and result in the accumulation of homocysteine, which spills into the blood and urine. One way to think of this disease is a person with Marfan's features plus thromboembolism. They are Marfanoid in that these patients have a tall, thin stature, pectus excavatum, long limbs and lens dislocation, called an ectopic lens, though in this case the lens is subluxed downwards and inwards, while in Marfan's it is dislocated superotemporally. Spontaneous thromboembolism may present as DVTs, strokes, and myocardial infarctions before age 20. Accumulated homocysteine and methionine are also associated with the development of mental retardation, osteoporosis, and childhood atherosclerosis. Homocystinuria can be caused by three possible deficiencies. The first, and most common, is a deficiency of cystathionine synthase. Treatment includes a diet low in methionine and high in cystathionine, B12, and folate, as these last three encourage homocysteine to become methionine instead of cystathionine. Many patients have partial activity of cystathionine synthase and therefore show a response to exogenous pyridoxine or vitamin B6 administration. The other two less common forms of homocystinuria are a decreased affinity of cystathionine synthase for pyridoxal phosphate, reducing its activity, and a deficiency of homocysteine methyltransferase, impairing the remethylation of homocysteine to methionine. Both of these are treated with vitamin B6. Homocystinuria is most often caused by vitamin deficiencies, namely deficiencies of folate, vitamin B12, and B6, and not genetic deficiencies.